Welcome to the e-learning module on pathology of ovarian tumor. So this is the continuation of diagnostic approach for a ovarian tumor. In this session, I'll be telling about the role of IHC in diagnosis of ovarian tumors. So the learning objective is to enlist various common IHC marker to differentiate various ovarian tumors. So what is immunohistochemistry? So what we use, the basic principle here is we use antibodies to detect antigen which is there in the tissue sample. So if the antibody which is used in a reagent binds to the antigen which is there in the tissue sample, tissue will stain certain color. So which can be viewed under microscope. For example, in this picture, this is a CK7 marker which is a ovarian cancer marker, epithelial tumor origin marker. So here this is a primary ovarian epithelial cancer and it is not some other tumor. So you can compare in these two. This is positive, that is brown color has been taken by the tumor cell. So this will suggest that it is a primary ovarian tumor. Whereas this is negative. So this background blue stain is a background stain which is a hematoxylin. So here there is no brown color which suggests that this tumor is negative. And this has taken brown color, this is positive. So that's how it is seen under the microscope. So coming to the marker based on our histopathology diagnosis. So based on histopathology, we will be having diagnosis of whether it is epithelial tumor, germ cell tumor or sex stromal tumor or metastatic tumor. So if you are suspecting epithelial tumor, the most useful set of markers are cytokeratin and EMA. So both positivity will suggest that it is a carcinoma. And nearly all primary tumors of ovary or fallopian tube, they are CK7 positive and CK20 negative. And also PAX8, which is extremely useful in confirming that tumor is of Mullerian origin. So all Mullerian origin like ovary or fallopian tube, they will be PAX8 positive. So lack of staining of CK7 suggests that probably the tumor is a metastasis. So primary ovarian tumors are CK7 positive, PAX8 also positive and CK20 negative. So if the tumor is CK7 negative and CK20 positive means it suggests that it is a metastatic carcinoma, and most common metastatic carcinoma to the ovary is from intestine or appendix. So these are the panel of antibodies which we use for differential diagnosis of epithelial tumors. So the most important, the first step is cytokeratin profile having CK7 and CK20. So we can also use CEA, CA125, PAX8 which tells that it is Mullerian origin, WT1 and P53 which is positive in serous carcinoma, GATA3 hormone receptor ERPR, they are also positive in gynecological malignancy, HNF1 beta and napsin A. So these are the set of panel which we use. So this table gives IHC marker which are utilized for subclassification of the epithelial tumors. So as we can see here, PAX8 is positive in all type of epithelial tumors. So what are the epithelial carcinomas? Serous carcinoma, in that high grade carcinoma, low grade carcinoma, endometrioid carcinoma, clear cell carcinoma and mucinous carcinoma. So we can use all marker to differentiate among these subtypes. So PAX8 is positive in all subtypes. WT1 is positive in high grade or low grade serous carcinoma. P53 is positive in high grade serous carcinoma. Napsin A and HNF beta also positive in clear cell carcinoma. PR can be positive in endometrioid carcinoma. So as you can see here, this is a high grade carcinoma, serous carcinoma, which is showing WT1 positivity, P53 overexpression, whereas napsin is negative. PR can be positive in set of cases. Low grade serous carcinoma, WT1 will be positive, P53 there can be focal overexpression. Endometrioid carcinoma mainly show PR expression. Clear cell carcinoma shows napsin A positivity. Mucinous carcinoma shows can be showing P53 overexpression, and all will be CK7 also positive. So coming to markers for sex-cord stromal tumors. So there are a set of markers usually which are positive in all type of sex-cord stromal tumors. So these most common markers are inhibin, SF1, colretinine, and FOXL2. So these are the standard panel for diagnosis of sex-cord stromal tumor. So EMA is almost always negative in sex-cord stromal tumor. So this is a helpful negative marker to exclude various other type of carcinoma when it is a differential diagnosis. So inhibin is a most specific marker. FOXL2 and colretinine is a more sensitive marker. SF1 stains almost all type of sex-cord stromal tumors. So what is the most helpful triad of marker can be utilized in diagnosis of sex-cord stromal tumors are inhibin and colretinine, which are typically positive, and epithelial membrane antigen, EMA, which is typically negative in sex-cord tumors. So diffuse staining for EMA suggests that it is a epithelial tumor. So you have to rule out other primary or metastatic cancer if it is EMA positive. So this is the example, inhibin and colretinine, both are cytoplasmic marker. So this brown color suggests that it is positive. FOXL2 is another marker which is a nuclear marker. Here the nucleus has taken the brown stain. So this is the table showing positivity of various marker in various subtypes of sex-cord stromal tumor. So as we can see here, inhibin stains almost all types, colretinine also stains almost type, and the most is SF1, which is showing 100% positivity in almost all types. So these are the panel of antibodies which can be used. So in addition to the antibody panel, hormone production is also a feature of sex-cord stromal tumor. So granulosa cell tumor or theca cell tumor is known to produce estrogen. So patient will be having menstrual related problem. She will be having increased bleeding during menstruation. Or Sertoli or Leydig cell tumor are known to produce testosterone. So they will have acne or hirsutism. So the hormone assay or symptoms related to hormone also helps in diagnosis of sex-cord stromal tumor. So next set of tumors are germ cell tumors. So germ cell tumors are most common in children or childbearing age, and in this type of tumor the treatment is by conservative surgery because they will be in reproductive age group. So conservative surgery is the treatment of choice followed by chemotherapy. So accurate diagnosis is very essential in giving proper management for germ cell tumor because of the age group. So ISC can be really helpful in confirming the diagnosis. So the set of markers what we use here are CD117, PLAB, OCT4, D240, AFP, Glypican, SAL4, CD30, HCG. So this will be positive in various subtypes of germ cell tumors. So this is the table showing various marker and their positivity. Dysgerminoma will be positive for SAL4, PLAB, OCT4 and CD117 or D240. Yolk sac tumor, the specific marker is AFP. In addition, SAL4 and Lin28. Embryonal carcinoma will be positive in first three marker like SAL4, OCT4, and also it is positive in CD30, which is positive only in embryonal carcinoma. Choriocarcinoma can be positive for HCG. Immature teratoma, there are no specific marker, but it can be positive for SAL4 or SOX2. So this is the diagnostic panel for germ cell tumor. So initially you will be ruling out the epithelial origin tumor by doing CK7, CK20, followed by the panel of antibodies for germ cell tumor like SAL4, OCT4, PLAB, which suggests that it is some dysgerminoma. If it is CD30 positive, embryonal carcinoma. So if it is yolk sac tumor, it will be positive for AFP. Beta HCG will be positive in choriocarcinoma. So dysgerminoma will be PLAP and CD117 D240 positive, embryonal carcinoma CD30 positive, yolk sac tumor AFB positive, then choriocarcinoma beta HCG positive. So these are the panel of antibodies when we are suspecting primary ovarian tumor. So initially we do CK7 and CK20, and also PAX8 can be done to confirm whether it is Mullerian origin tumor. Then we can go ahead with inhibin CD99. If it is inhibin and CD99 positive, or SF1 FOXL2, it will suggest that it is a sex cord stromal tumor. So depending upon our DD, we can use various other markers like FOXL2. So if it is not positive for sex cord stromal tumor, we can use the germ cell tumor marker like CD117, CD30, PLAP, or any other markers which are already told previously. So these are the protocol to be followed for diagnosis of ovarian tumors. These are the references for the lecture. Thank you.